Xtalks connects professionals in the life science, medical device, and food industries with useful content like webinars, job openings, articles, and virtual meetings to help you succeed in your career. This podcast brings together some of our editorial staff to share insights into the latest B2B industry news to help keep you up to date.
Hello and welcome to the Xtalks Life Science Podcast. I'm Ayesha Rashid, Senior Life Science Journalist at Xtalks.com, and this week I'm especially delighted to introduce two very special guests on the show today. We have with us Dr. William Schaffner, Professor of Preventive Medicine, Health Policy, and Professor in the Division of Infectious Diseases at Vanderbilt University, and Dr. Kelly Moore, who is the President and CEO at Immunizeorg, as well as Adjunct Associate Professor of Health Policy at Vanderbilt University. Dr. Schaffner and Dr. Moore will discuss the FDA's Vaccines and Related Biological Products Advisory Committee, or VRBPAC's, recommendation of a trivalent influenza vaccine strain selection, with the 2024-2025 influenza season reflecting the removal of the B. Yamagata strain. Dr. Schaffner's primary interest has been the prevention of infectious diseases. Early on in his career, after residency training and a fellowship in infectious diseases at Vanderbilt, Dr. Schaffner served in the U.S. Public Health Service as an epidemic intelligence service officer with the CDC in Atlanta. While with the CDC, Dr. Schaffner became intimately familiar with public health and investigated outbreaks of communicable diseases both in the U.S. and abroad. He returned to Vanderbilt after that tour of duty, joining the faculty and establishing a long collaboration with the Tennessee Department of Health. Dr. Schaffner is a strong proponent of collaboration between academic medical centers and public health institutions. He has worked extensively on the effective use of vaccines in both pediatric and adult populations, and has been a member of numerous expert advisory committees that establish national vaccine policy. Dr. Schaffner was the medical director and past president of the National Foundation for Infectious Diseases and has served on the executive board for the Infectious Diseases Society of America. Before her current role as president and CEO at Immunizeorg, a leading nonprofit organization focused on national and global vaccine policy and immunization program implementation, Dr. Moore served for 14 years as the director of the Tennessee Immunization Program and later founded her own consulting company, the Vaccine Advisor, to advise public health and industry. Dr. Moore has served in a variety of immunization policy advisory roles with the World Health Organization since 2016, including as chair of its Immunization Practices Advisory Committee. Dr. Moore has a long history with the Advisory Committee on Immunization Practices, or ACIP, as a working group member, liaison representative of the Association of Immunization Managers, and as a voting member as well. Dr. Moore is a graduate of the Vanderbilt School of Medicine and the Harvard School of Public Health. She completed her public health leadership training as an epidemic intelligence service officer and preventive medicine resident with the CDC. To learn more about the state of domestic and international infectious diseases, including the importance of providing vaccines that most closely match circulating flu strains, let's turn to Dr. Schaffner and Dr. Moore. Thank you both for being on the show today.
Good to be with you, Ayesha.
Great to be here.
I'd like to start off by first asking you both about your journey and what drew you to infectious diseases and vaccines, and how your journey has led you to so many important endeavors and so many significant accomplishments in this space.
Well, I'll start off as a young medical student. Actually, a professor made the comment when I was a student that about 95% of the people in the world who are dying of infectious diseases were dying of diseases we already knew at that time, either how to easily treat or prevent altogether. And that comment resonated with me. And I determined at that point, I wanted to focus not on creation of new knowledge necessarily, but on the implementation of that new knowledge for the people who needed it. And my MPH program in international public health and experiences as an epidemic intelligence service officer demonstrated how working with systems in public health and healthcare could help prevent so much suffering through immunization. And it just became a passion of mine to focus on how to make the right thing to do much easier to do for the people who need these interventions.
Yeah, my road, I guess, to infectious diseases is somewhat similar. Even before I went to medical school, I had read that old book by Paul de Kroof, Microbe Hunters, and it was infused with intellectual stimulation as new diseases, new microbes were defined, and there was a sort of adventure associated with infectious diseases. And then when I was in medical school, back in those days, we actually had summers off. I worked on a research project sponsored by a faculty member in Mexico, and it had to do with infectious diseases. From that moment on, I was hooked.
You were hooked and never looked back.
Exactly. And my time, as with Kelly, at the CDC just reinforced that. And when I got back to Vanderbilt, Vanderbilt was very generous. It allowed me to go down a path less traveled. I was a clinician, consultant in infectious diseases, but I was also able to work with our state public health department on a variety of projects. And that's continued to this day. A most fortunate for me.
And for the rest of us.
Absolutely. And so having two expert infectious disease professionals, leaders in the field, it's such an honor. And I'd just like to ask you, coming out of the COVID-19 pandemic, how have you seen the evolution of people's attitudes towards infectious diseases, both public perception as well as how has the pandemic affected the medical community as well, of course, in the arena of infectious diseases in terms of research, clinical practice? How has, I mean, you must get this question a lot, but we talk to a lot of infectious disease experts like yourselves, and we look to you for guidance during those difficult times. But I'd like to know what the impact has been on you as well.
Bill, would you like to start?
Well, I'll start, but Ayesha, that's a very sobering question, actually, because COVID actually exposed and accelerated the skepticism, the lack of trust in public health authorities. And truth be told, our friends at the CDC and some of us also did some missteps. And so that eroded the confidence that the public has in public health. And we're having to earn that back the old-fashioned way by doing good work going forward. And the current and recent past CDC directors have acknowledged this and have urged and stimulated their staff at the CDC to earn that back. So we're working on that. And particularly, as you know, when it comes to vaccines, there was this, despite the extraordinary achievement of quickly developing these wonderfully effective vaccines against COVID, at the same time, a great deal of skepticism and hesitancy and even rejection in some quarters of these vaccines have occurred, and that's spilled over to other areas. So not to go on and on, we're going to have to restore that trust through our good work.
I agree. And along with what Dr. Schaffner was focusing on, I think it's just been a tremendously tumultuous time. It's been, as the old story says, the best of times and the worst of times. There's been a lot of funding and a lot of focus and a lot of excitement with new platforms like the mRNA platform for vaccine development that shows a lot of promise for other applications. So in we have been able to do things we've never done before, but we've also had to contend with this sense of public distrust, and in some cases, those who sought to leverage public emotion for their own ends against scientists and physicians and public health professionals. And in some ways, that's been a bit bewildering. People are quite accustomed to sort of being in the background, but always being respected and listened to. And when you start talking about what people should do and they say, I just don't believe you, I think many of us are still wrestling with how to respond to that. It's a new world. And those of us who are involved in health communications are having to learn new strategies from others, maybe with expertise in other fields, to figure out how to reach people with such a degree of distrust in where we're coming from. So it's been a challenging time, and it will continue to do so, but we will rise to the occasion.
As you always have, and you absolutely will continue to. And we can't thank experts enough for having to grapple not only with understanding the science, but the social attitudes, socio-political attitudes, may I add, towards infectious diseases and vaccines and everything that goes along with that. So cannot thank you enough for the work that you've done and that you're continuing to do. So I'm sorry I threw in the COVID thing because I just thought it was a good way to start off with the infectious disease area and arena. But those were stellar discussions and comments. Thank you. All right, so we'll get into influenza. So we heard about the FDA's VRBPAC recommendation to transition from quadrivalent to trivalent influenza vaccines for the 2024-2025 flu season. So, Dr. Schaffner, can you explain the significance of this recommendation?
Well, as you know, Ayesha, we have had for some time now quadrivalent influenza vaccines. In other words, the influenza vaccines that we've used have had 4 components. They protect us against 4 influenza variants, because usually there may be a dominant influenza strain, but there are usually several strains out there circulating during the influenza season. So it's a bit of a shotgun rather than a rifle. You can think of it that way. Now, the World Health Organization, under its umbrella, conducts surveillance for influenza and its variants around the world. And we're doing a better and better job with that. We're looking harder, and we're looking in a more sophisticated way than we even did 5 years ago. Now, as a consequence of that, they have discovered, we have not seen B. Yamagata, one of the 4 strains that used to be in the vaccine, anywhere in the world. We haven't picked it up from any human being or any animal. And it's simply not been there since March 2020. And so the question came up, again, under the aegis of the World Health Organization, and our Food and Drug Administration participates in these discussions. Gee, if it's not out there, why are we including it in the vaccine? And so people have talked about that for a while to be absolutely sure that B. Yamagata isn't suddenly going to appear somewhere, but there's now a level of confidence that it's truly gone. Why and how? I'm not so sure we know, but it appears to have evolved away from us. And so it was decided for this coming season, the next season that we're going to immunize for starting this September, that we would go back to having a trivalent vaccine. We didn't need that 4th component. So the reasons are very simple. We don't want to vaccinate against a virus that's no longer there. Easy peasy.
And I'll just add, because I think this is a great example of scientific community responding to evidence. and the value of investing in these surveillance systems. We could only make this decision because we had the data to feel confident about making that decision, and that required global collaboration and investment in surveillance. But it's important for everybody to understand that when we have good information, we should adjust, and we can adjust our response to disease control based on that evidence and redirect our energy and resources where they're most needed.
Absolutely. And that's what science is all about, and evidence-based medicine, where you evolve and change with the data. So absolutely. And so how long has the B Yamagata strain been included in the influenza vaccine?
I hope Kelly knows that.
Sorry, I just thought of that. I was
going to say quite a while.
Sorry, we can cut that out.
I know that Yamagata evolved out of Victoria at some point in the distant past, and that they kind of took turns showing up, but we usually pick the wrong one about half the time. And so, it's a descendant of Victoria, the other type B strain that is still around. But, we've had strains come and go of influenza over, we've always had them come and go. This isn't a unique experience. Right. We've seen other strains drop out and be replaced by others over time. And so it's great to have the data to feel comfortable that that's what's happened, but it's not new or unusual with influenza.
And so what implications does the removal of the B Yamagata strain have from the upcoming flu vaccines for overall public health strategy? And also, would it make sense to replace it with another strain? I suppose not, if there is no strain that is dominant enough that's in circulation to be added. So maybe it could be a bivalent vaccine, or so I guess it depends on the strains in circulation, or does it have to be a certain valency every year?
Well, it doesn't have to be a certain valency, but there are usually, as I said, a multiplicity, several strains that are circulating, and they are from the A and the B lineages. And it just happens that now we have kind of one B lineage, the so-called A Victoria strain, which is out there. Yamagata has gone away, and so we needn't include it anymore in the vaccine. You ask what sort of changes that might make, or what sort of implications it has. And I'll be very interested in hearing what Kelly has to say about this, but I see it as kind of two possible responses. One is 90%, I'm making up this number, of both the people out there and the practitioners. They just say, give me the vaccine you recommend, and we'll give it. And the patients say, we'll take it. Now that's 90%. Now, there is a 10%. They are the people who pay very close attention. And this includes patients as well as providers. And they are a little bit of influenza vaccine nerds, right? They pay attention, and they will want questions answered. And I would anticipate answering their questions, but not bringing it up and belaboring this issue, because it's very straightforward. And I think we can answer the questions of the folks who are really interested in a straightforward fashion, just as we're doing here.
And I agree with Bill in that the really, for the majority of people, there's no change in public health policy or public health strategy associated with influenza vaccination. It remains the case that every person aged 6 months and older needs an influenza vaccine this fall. There will be a slight adjustment in the number of strains represented in that vaccine, but the timing is exactly the same as usual. The prices will probably be the same, in that most people will have insurance coverage to cover it. They're not going to notice any difference. And we still need to get the population vaccinated. And it's valuable for the people who are curious to know that this is a sensible, evidence-based response to data that simplifies manufacturing perhaps in reducing it from 4 to 3 strains that they need to get just right. However, it's really more of an issue for the manufacturers and regulators. That certainly, there's a lot of burden on them in terms of getting everything adjusted, but the adjustment is going to be seamless for the general public and for most healthcare providers.
And over the past couple of years since COVID, what has the landscape of influenza vaccination been like? Has uptake increased, decreased? I know there was maybe a slight decrease during that first year of the pandemic just because of the lockdowns and people hesitating to go out to clinics or to see their doctors to get vaccines. But what has the trajectory been like in these past 4 years, and how are things currently?
Well, I think we can both speak to that.
No, go ahead. No, go ahead, Kelly, and then
I'll do the basics, and then you can
Sorry,
do the
this is a question to you both, so I didn't know.
I'll do the color commentary, right.
Right. Actually, the very first year of the pandemic, before we had a COVID vaccine, we had huge numbers of people turning out to get influenza vaccination because that was the only vaccine they could get. There was no COVID vaccine, and so people were attuned to protecting themselves from what they could protect themselves, although the virus didn't really show up because everyone was staying at home and, as you say, confining themselves. So they were well vaccinated, but there wasn't much circulating because the method of spread was interrupted by people staying at home. As people adjusted and stopped their social distancing, stopped their mask wearing, became more social again, and then acclimatized to having access to COVID vaccines, unfortunately and paradoxically, we saw a diminishment of passion about getting influenza vaccination. And particularly in the last couple of seasons, we've been concerned about attitudes about vaccinating children, school-age kids, and also influenza vaccination during pregnancy. And what's really frustrating for us as professionals is that more and more evidence is emerging of the value of influenza vaccination during pregnancy and in children and people of all ages, and what it can prevent and the benefit it has. And how safe it is. And while all that evidence is coming out, people are retreating from getting that vaccination. And so we're dealing with public attitudes that are not aligning with the data. And so we have concerns that we need to reinvigorate people's passion for influenza vaccination and the protection it provides. And this season is a great season for it. We saw very good protection from the influenza vaccine this year, and yet a lot of people missed out on taking advantage of that protection. Dr. Schaffner, what would you add?
I would just add this last year was a special challenge. Because not only were we asking people to take influenza vaccine and the updated COVID vaccine, you have to roll up both your sleeves, right? For people age 60 and older, there was also the consideration about whether they should get yet another new vaccine, RSV vaccine. So it's starting to get crowded and a little bit confusing, particularly at the older end of the age spectrum. And so for providers who are kind of learning about RSV vaccine themselves, it was a little bit confusing, and also for patients. So last year, I think, was kind of a trial run, and I hope we get more efficient going forward. But it will take education. There isn't any doubt. And when I say education, yes, providing information is critical. But as we've all learned, it's not education. Facts are important, but often not sufficient to change behavior. It's their attitudes. It's not how they think, it's how they feel. They need to be comfortable and reassured, and that it's the socially appropriate thing to do. And we in public health need to become more aware that we have to address these comfort, reassurance, and socially appropriate issues rather than just giving them the data.
I think we often get lost in the data on the science side, but definitely it comes down to how people feel, and that emotional response dictates their actions ultimately. And so what types of approaches are going to be needed? And both of you mentioned how coming out of the pandemic, new strategies potentially will have to be adopted to regain trust, to re-educate, or to retool people towards vaccination. So what kinds of strategies do you think will be necessary, novel or tried and tested ones?
Well, Ayesha, all the studies, the surveys, year after year, indicate that the single most important determinant about whether someone receives a vaccine is if they get a strong recommendation from their provider, their trusted personal provider. No matter who the provider is, a physician, an advanced practice nurse, a pharmacist, whatever, someone whom they know and trust. And I think we're going to have to get better as providers in making those recommendations. And we're going to have to address those comfort issues. I'm a kind of a more personal type of doctor rather than formal and standoffish. So if a person expresses a concern, the first thing we do is mirror back to them that we've heard them and it's okay. Oh, you're expressing a concern about that. I hear that a lot. Oh, all of a sudden it's okay, and other people are asking the question. And then as we talk about it, I will frequently say, I'm vaccinated and everybody in my family is. And if you go out and look around, every nurse, every doctor in this clinic is vaccinated, and we're trying to vaccinate absolutely every one of our patients. Oh, I'm trying to make it the social norm in order that you all have the benefit of the prevention the vaccine can give. And then I keep listening to the patient and trying to respond and letting them know that their concerns are valid. I've heard them, and I'm trying to provide a good response that will make them feel good about getting the vaccine, as opposed to thinking good about getting it.
And I will add another dimension of that hesitation is sometimes just anxiety about needles. Simply, it isn't, sometimes the concern about the vaccine is simply masking the fact that they find needles and injections distasteful. And that also is incredibly common. It's not just kids who don't like shots. And so another strategy that we recommend and provide support for at immunize.org are tips for vaccine recipients who are anxious about needles to feel more comfortable and address their anxiety, because if they feel better, they feel more in control, then they're not going to experience as much pain and have a better experience with that injection, and then be less hesitant about the next one because they know how to handle their anxiety. And so for many people, that can make a difference. It takes different strategies, as Dr. Schaffner said, customized to that patient and letting them know it's okay to have questions, concerns, or anxiety, and that we're equipped to help them deal with that.
And Dr. Moore, you mentioned at immunize.org. I'd like to learn more about your work as president and CEO of the organization, and how you leverage the platform to inform, again, on the topic of informing and educating the public about vaccinations and infectious diseases. And so what does your work at the organization entail?
Well, immunize.org focuses primarily on supporting healthcare professionals as they implement vaccination recommendations from the CDC and try to make sure that people receive exactly what they need when they need it. So a lot of our resources are focused on the support that healthcare professionals need. We may develop templates for them to have simple standing orders, clinical resources, patient education sheets, and other even simple things around coding and billing that can help them simplify the process of delivering immunizations on a large scale. And so we have a suite of resources every year that are updated to reflect the most current recommendations and to help people think through how they're going to deliver not only influenza immunization, but also COVID vaccination and RSV immunization, and address those considerations and juggle all of those demands in a way that works for their workflow to deliver the vaccines and products that people need when they need them. So we are less involved with the patient directly and more focused on supporting those healthcare professionals to feel confident making those strong recommendations, addressing myths and misinformation, and reassuring patients around things like vaccination anxiety. One of the things we're choosing to do this coming fall is simply not really referring to the number of strains in any particular vaccine. We'll drop the trivalent, quadrivalent conversation because ultimately that influenza, other than an acknowledgement of the difference, but really, eliminating a strain that is no longer in circulation is not going to be clinically relevant to that patient or to the healthcare professional's decision about what influenza vaccination to provide or when to provide it. So we're adjusting our approach to respond to the evidence, but also to try to make it easier for healthcare professionals to feel like it's not a big deal that they need to go into with every patient. Try to make it as to minimize the confusion associated with this minor change.
Absolutely. And it goes back to Dr. Schaffner's point of the healthcare provider being that trusted source. And so at Immunizeorg, that is exactly what you're doing. You're producing those trusted healthcare professionals. And
Ayesha, one thing I neglected to add that I should mention, one of the resources we provide is a section of clinical questions and answers called Ask the Experts. It's been around for over 25 years, and it's often a place where a nurse who can't find the answer to what she's looking for at CDC's website or in the published guidelines can say, okay, I've got this clinical situation. How do I address this? And often we have something in our repository of over 1,300 questions and answers that will address that clinical scenario. And that's a really popular section of our website for healthcare professionals to use when they can't find the answers somewhere else.
That's excellent. It's crowd brainstorming and bringing all of that information together in one database, which is excellent. Definitely trumps going to ChatGPT or something like that.
Please.
Yes. And so you both did touch upon other viruses and the new RSV vaccines. And so what are your thoughts about a potential trifecta of a vaccine? I know there are companies, I believe Moderna and Pfizer are developing vaccines that will include influenza, RSV, and COVID. So what are your thoughts on that? And given your experience and expertise, both on the healthcare provider and public health end, how do you see its reception?
Well, perhaps I'll start. There are scientists in academia, at the NIH, and in the vaccine manufacturers who are working on combination vaccines. We won't have them available this fall, I'm afraid. But maybe next fall, we might have a combination COVID and flu vaccine at the very least. That would be great. But the development of vaccines is rarely a straight line, and so we can't count on that. But certainly going forward, if we take a kind of a longer horizon, in addition to combination vaccines, there are other scientific goings on that may, for example, create vaccines that offer better protection. You know, the influenza vaccine is a good vaccine, but it's far from perfect. We all acknowledge that. And so perhaps that would offer, we might call it stronger protection. And also, there's also been interest in the so-called universal influenza vaccine that would protect against a whole variety of different types of influenza. Same for COVID. In other words, we might not have to change the vaccine as frequently if we had one that linked onto parts of the virus that was conserved. In other words, the same in all the different strains. That's a scientific challenge, but there are people working on that. And then the last thing I'm looking forward to is, wouldn't it be wonderful, apropos of exactly what Kelly was mentioning a moment ago, if you could free up the delivery of influenza and other vaccines from the needle and syringe. And there are people who are working to try to get patches with little tiny micro needles so that you could go around and just slap a patch on your back and leave it there for 48 hours and get vaccinated. Or there's even a group working on trying to deliver the influenza vaccine via a capsule.
Yeah.
Now just think about how, this is way out of the box, but think about how we could revolutionize how we deliver vaccine. You wouldn't need all those people with fancy letters after their name like RN and MD. We could train high school graduates how to do that. They could go into a senior citizen center and just pop a capsule into everyone's mouth or slap a patch on their back. We could go door to door. There are all kinds of things that are possible that have to be organized, structured, paid for, and all that roll. But we could think about ways of vaccine delivery that are really 21st century. We're not there yet, but there are people working on such things.
And moving forward, you both did mention about the importance of global surveillance in monitoring the various strains for influenza and other infectious diseases as well. And so how has that landscape changed? I keep going back to COVID, but I just feel like it's changed so many things. And so within the infectious diseases community, do you see greater collaboration? Do you see changes in attitudes? And how has that surveillance improved, changed, and how is it moving forward with possibly new innovations, AI, and all of these new technologies coming into play that we can't escape? But how is the global surveillance of infectious diseases like influenza evolving?
I can say a few words about it, and then Dr. Schaffner can fill in. But I think we've seen tremendous advances and investments in global surveillance, and we also have become aware, and obviously now we're acting on the benefits of having comprehensive information from these surveillance systems, and we recognize how much we can do if we have good information. The concern I have is, will we continue to invest in those systems? Because those systems are not cheap and they require manpower and resources around the world. And during the especially early days of the COVID pandemic, there were tremendous investments in building up capacity. And what all of us in public health fear is that when the crisis ends, we will walk away, we'll take our money and go do something else, and then come back and rebuild this structure when the next crisis begins. And that's just, we've seen that over and over again throughout our public health history with different crises, and it's unnecessary and really regrettable if we were to make the same mistake here. So what I would certainly be working to encourage is continued investment in these global surveillance systems, because we recognize the value of those data to making clear evidence-based decisions. This influenza season is only one example. We look at emerging influenza strains around the world. Just today, we saw an announcement from the CDC about a dairy worker in Texas who had been infected with a high-path avian influenza strain that was acquired in their farm work. We need to know what's going on, and where it's happening. And we need to continue to invest in those systems in order to take the most effective public health actions and communicate effectively to the public. Dr. Schaffner?
Well, I would just emphasize everything you've said, Kelly. The pathogens, the germs, the viruses, they don't need passports, and they circulate very quickly. COVID was extraordinary. Within a matter of months, it began obviously in Wuhan, China, but in a matter of months, it had spread to every continent on the world, with the possible exception of Antarctica. And so we do live in a global village. COVID, I think, has taught many countries that it is better to communicate quickly and accurately to colleagues around the world. It's in their own interest. And speaking about people here in the United States who find that strange, I remind them what's over there is only a plane ride from over here. And therefore, we have to invest not only at home, but we have to extend our resources abroad to bolster the capacity of other countries to do surveillance. We make friends that way, and we can help other people in other countries while we are protecting our own population. Public health is marvelous in that way. It provides benefits to all populations, and we increasingly, we always, I think now, have to take a global perspective.
And to end off, I'd like to ask the both of you, in terms of looking ahead, what are some of the key milestones or advancements that you both hope to see in the coming years in the space of influenza prevention and vaccination and vaccine education? And how do you believe these advancements will help to shape the global response to not just influenza, but emerging infectious diseases as a whole?
Well, I know Dr. Schaffner mentioned a few of those earlier, and one of the most important things that I would like to see as an advance is reaching beyond that seasonal vaccine effectiveness of 40 to 50%, as beneficial as we know that is to the population overall when it comes to influenza prevention, with a disease that it sickens tens of millions just in the United States every year. We have a long way to go, especially in older adults who suffer the greatest burden from influenza infections. And we know that when people see that the vaccine will really work for them, look at the example of shingles protection or RSV prevention in babies, new example of a really effective intervention. We're seeing people clamoring for those vaccines. And I think sometimes we in public health think about the population, but forget that sometimes a person may see a modestly effective vaccine like influenza as not being of enormous benefit to them individually. We see it as a tremendous benefit to them and to their community, but sometimes they can lose that message when it's really obvious they really want the vaccines. And that's encouraging. My wish list for the next decade definitely includes that universal influenza vaccine that will be durable against the annual drifts and the occasional shifts in the influenza viruses. And I'll tell you, I would love to see breakthroughs in the basic science of influenza immunization. If we could understand better in the laboratory whether a vaccine will work effectively in the real world, it would be enormously helpful if we didn't just have to rely on real world experience with testing a vaccine out in the community and seeing what happens, because sometimes influenza shifts and sometimes it drifts and sometimes it doesn't show up. And we often struggle to understand just how well the products are working that we're developing because it's difficult and expensive and slow to study them. I'm also really looking forward to changes in influenza vaccine platforms and how we can continue to advance in those, both in terms of speed and effectiveness. We have mRNA, cell-based, recombinant technologies, new adjuvants or additives that can enhance the vaccine's effectiveness that may all affect the durability and the degree of protection from severe disease. And those are going to be coming in the next decade. And it's going to be an exciting time to see what happens. And, all of those advancements, whether it's in disease surveillance, artificial intelligence, and how it can be used to help us better predict, to create models that will predict what's coming, those are going to make us more effective at developing vaccines that will work in the season ahead. Influenza is always a challenge because none of us can predict the future when it comes to these viruses. We just know things will change. We just don't know how. And maybe these tools can help give us a better model of how they might change in the future. And then, we also have things like monoclonal antibodies that are brand new technologies that hold promise for those who may not benefit from vaccination directly. So there's a lot to come that's emerging technology. And I hope that we will continue the investments in these new developments to bring these to fruition to benefit the public. And then immunize.org will be right there ready to help healthcare professionals deliver those advances to the people who need them. Dr. Schaffner?
Well, let me just say very briefly, because I talked about some of the advances in enhancing the effectiveness of the vaccines and better ways, easier ways to deliver the vaccines. I would just remind people that disease is bad, vaccines are good. We'll start there, and that although we're making advances, waiting for perfection is the great enemy, Voltaire told us, of the current good. And we have, for example, good influenza vaccines available today, and we need to take advantage of them today while we are hoping for and awaiting even better vaccines in the future. The 20th century was a century of vaccine development and deployment. I think the 21st century, this one, is going to see even more vaccines, and they'll be deployed even better for the benefit of humankind around the world.
And with that wonderful message, I'd like to thank the both of you, Dr. Schaffner and Dr. Moore, for being on the show today. I cannot thank you enough for your time and for your valuable, valuable insights. Thank you so, so much.
Thank you.
Welcome. Thank you.
And that's the end of this week's episode of the Xtalks Life Science Podcast. If you liked today's show, don't forget to rate, review, and subscribe. Thank you all for joining us, and see you next week. Bye for now.
If you enjoyed our discussions today, please share the episode with your friends and colleagues, and be sure to subscribe in order to be notified when a new episode is released. To join in on the discussion, you can find Xtalks on social media, email podcast@xtalks.com, or comment on the articles directly. Links are in the show description. Take a moment to join our community at xtalks.com to get access to everything we have to offer, including webinars, job listings, virtual meetings, articles, and more. The views and opinions expressed in the podcast are those of the speakers sharing them. They should not be taken as professional advice and do not necessarily reflect the policy or position Honeycomb Worldwide. For further information, email us at podcast@xtalks.com. Thanks for joining us, and we'll see you next week.